have lots of studies. I'm going to spend the next hour talking about nuclear factor kappa beta. Is that how it goes? Maybe not. I don't have any studies. Now, one single study in here. I'm a day-to-day clinical practitioner from Detroit. We just get things done over there. So that's what we're going to do, and I want to thank you for taking the time to come here and learn about this and see about this. And so between Steve and I, we're going to kind of wrap the day up. But I'm going to start first by letting you know that I have been paid sometime from different people to do these types of presentations, but not today. And one of the things that I would want to make perfectly clear is that Quest Diagnostics didn't make any of the clinical decisions in any of these cases that you're going to see on the screen. And there's only a couple today. I usually do longer programs with a lot more cases, but today there's just a couple. I do get a lot other little tidbits. Next year, if you get a salami sandwich, a coffee from any one of these companies, you're going to have to disclose it. So they'll throw us a bone every now and then, and so we got to let you know that. I also have a financial interest in a company called Impact Dental Solutions, and that's a company that I created that helps practitioners put knowledge into motion. It's always difficult coming to these courses, getting great ideas, and then trying to figure out how to go home and make it work in your practice. And so we can help you with that, should anyone be interested. It is about the collaborative relationship. That's significant. I've built that at home with a lipidologist. I built it at home after I came to one of the Bale-Donin seminars and thought, wow, this is kind of cool. Maybe that's where some of you are today. Maybe you're a physician, maybe you're a dentist. But you have to, once you get the spark that you want to get this happening, you're going to have to build that relationship. And that's what it's about. I can tell you that one of the experiences I had that motivated me even more was I was in church, and one of the church participants came in, and I turned to my wife and I said, Jane, what happened to Tom? He looks terrible. And so he went to the back of the church, and I went and followed him back there, and I said, Tom, what happened to you? He said, over the last 2 months, I've lost 40 pounds. I feel terrible. I went to the VA hospital in Detroit, and they told me that everything was fine. They took some blood studies. They did some work. They said everything was fine. They sent him home. He continued to deteriorate. Then he went to the Ann Arbor VA. He went to the Ann Arbor VA, and they told him that after duplicating the same blood studies they did in Ann Arbor, that you were, in fact, fine. He was a veteran of foreign wars. He didn't have any insurance. That's why he was using the VA facility. And so he continued to ask questions. Then they did a CAT scan. And on the way out of the parking lot, the physician called him and said, you need to come back. Because on the CAT scan, he had a nucleus of infection on his spleen, his heart, and his brain, base of his brain. Then they looked in his mouth. After they looked in his mouth, he lost 6 teeth. He lost all the back teeth. Right now, he's completely edentulous in the maxillary arch. He was very sick. He had a PICC line for several months, almost died. It was a terrible, terrible thing. And then he said to me, my dentist actually cleans my teeth himself. And he uses that little vibratory wiggly thing, you know, that goes around the teeth. And he says he's never said anything to me about my teeth. That's a travesty. I mean, that's just wrong. And we want to prevent that from happening. We don't want stories like Tom. And in fact, if you look on the pan, here's some calcifications in the carotid areas or in the vascular areas. This is a bad, bad deal. So we don't want that to happen. Hence the arteriology issue, right? Let's look at and let's think about how do we determine if the patients in our practice might have some other issues going on other than just periodontal disease. And how does periodontal disease figure into this whole process? So thank you for being here, and hopefully you can change some lives as well. My education started at the University of Michigan School of Dentistry in '96, and then I moved on to that same VA that Tom was analyzed at. That same VA, and that's where I started to learn the appreciation for the sick patient, the patient that had other considerations. It was interesting to me that at the VA we had to do surgical clearance all the time for patients. And then I got out into private practice, only 40 miles from that building, and we didn't do any of that. And how could that be? Well, the fact is we need to do it more often. And this is where it started for me in private practice. I don't know if you get these in your neighborhood, but this really made me mad. I got one of these coupons in the mail. I opened it up, and it said you can get your teeth cleaned, you can have the harmful bacteria around the teeth removed, you can have x-rays, you can have an exam with the doctor, you can have any necessary anesthesia, and the value of the coupon was $248.50. I thought, wow, that's kind of expensive. $250 to have a prophy. Well, guess what? It was for my cat. Okay? So then I said, what is going on here? I can't get my patients to pay $97 for a prophy, and I got to pay $250 to have my cat's teeth cleaned. The veterinarians were doing a better job at educating their patients than we were. So I gathered my troops. I gathered my troops right in the lobby of my little Detroit practice, and I said, we are going to stimulate hygiene business. That's what we're going to do. It just made me mad. We're going to stimulate hygiene business. And so that's kind of what we did. But we stimulated hygiene business under a little different approach, and I didn't even realize what I was doing back then. I just got mad about the cat coupon. And so what happened was I initiated a periodontal policy in my practice. In other words, I created some hard, fast ground rules about how we were going to work, how we were going to identify periodontal disease, what it was going to mean. I mean, very succinct criteria, and that's what I'm suggesting that you do with this information today. And I want to show you what happens financially in your practice if you do that. I want to give you a snapshot. Nobody likes to talk about financial numbers. I'm going to share some of those with you because it's real. When you go from doing pro fees, and this is 2006 when I started doing this. This was the base year. The little coupon came in very early 2007. And so basically what happens is you do a lot more SRPs. You use a lot more antimicrobials. You do a lot more perio maintenance. You prescribe a lot more RX paste or fluoride paste for exposed root surfaces if you're doing scaling and root planing. In other words, we created a policy to identify disease earlier, treat the disease more succinctly, and follow up with the patients on maintenance much more critically. And when we did that, it made a difference in the baseline revenue and the change in gross production between not having basically a prophy palace, which I had not that many years ago, to 2009, which now I have basically a personalized periodontal medicine experience for my patients. It made a difference of a couple $100,000. So it's worth it. Your trip today will be worth it. And if you're a physician working with somebody, you're going to do a lot more testing and disease identification, and it'll be worth it. And that was in 2009. In 2010, because now it's the next year, we're getting a little more savvy, a little better, we're getting more informed. The difference was about $300,000. And so it's just a shift in what you do. It's the same patient base, it's the same tools. I didn't add any other thing. All I did is change my thinking and changed our approach to disease. It made a really big difference. How about ongoing? I stopped adding up the pennies or counting the widgets in 2010, and I went on in 2011, and we'll just look at some production ratios. I work in a little what we call a solo group practice. If you walk into my waiting room, there's 3 practices, and I work out of 4 operatories, a very small practice. And so if you turn down the hallway to the left, you get to my practice. If you go to the right, you get to some other people's practice. Same front desk, same waiting room, same building, same demographics. It's identical. This was for October of 11, October 3rd through October 31st, so basically a month. My practice that month produced, actually it was to, October, yeah, it was about a month. My practice produced $97,000 that month, and I produced 43% of it. 43% of a $97,000 month. On the practice down the hall, they produced $76,000, and the practitioner produced 65% of it. And that's about kind of a normal ratio, 70%, 75%. The other practice produced $74,000, and then they produced 65%. The practitioner produced 65% of that. So you get a shift. You get basically a shift in who's able to produce the income and the revenue in the practice. And that's significant because it allows an opportunity for you to share more with your hygiene team, which are now, we call them periodontal therapists, or no longer hygienists, and it works really nicely. And then how about for the year? What about, you say, well, this is a good month, Doc, you picked the best month. How about for a year where we go from January, now this was January through October, so it wasn't a full year because we had November and December to go through yet. But at that point in 2011, I was at 1.1 million, and I had 53% was produced by me instead of out of a 4-operatory practice instead of the hygiene team. The 2 practices down the hall, same number, same exact thing. 602 was the production, and that practitioner produced 65%. This practitioner was 761 and produced 70% of that. So significantly, this carries through. This carries through year after year. That's just how it's going anymore. And I won't share any more financial information. I can tell you 2012 is panning out to be the same way. And if anybody knows anything about Detroit, it's not an economic powerhouse. I mean, it's tough there. It's tough sledding in Detroit. So here's what I would call it now. If you went home from this meeting and you said, I want to corral my troops, I want to get everybody together, this is what I would say. Hey guys, we want to focus on total body wellness, and we want to practice better periodontal medicine. That's what we want to do. It's not that you haven't been doing a good job, but now you have the tools and the knowledge to do something better. and I want to show you what that means. Because our focus is changing. You've heard it here today just over and over again. And really the main focus is we're going from repair to prevention, because we have been repair houses, and your patients think you fix things. That's what they think you do. They know the physicians manage disease, but they think you fix disease. And that's a problem, because the patients have to have a little bit of a paradigm shift. And then we used to think that bleeding was okay, but it's not okay. In my practice, bleeding gums is a big problem, and zero bleeding is really the goal. And I've heard a lot of things. We're going to have a roundtable discussion afterwards about disease treatment protocols and what do we expect. And I can tell you, if you test your patients with bleeding gums, you're going to get bad results, because we've already proven succinctly that it's bacteria that drive that bleeding. And then there's no question that we're going to go to more proactive strategies. We're not concerned about tooth loss. Our traditional periodontal care was focused on saving teeth. Now we're focused on systemic health. So that's changed. And inflammation, in fact, is being redefined. It's being redefined, and Dr. Bale and Amy Doneen are helping us with that, and other people are helping us with that as well. Because guess what? The periodontal patient that needs treatment in your practice is going to look like this. It's going to look like this. There's no obvious inflammation. Looks pretty normal, but you have to go searching now to figure this out and to ferret this out, and you'll be able to do that. There's no question that the biggest current concept that I heard today is this: as far as gum disease, it starts with bacteria. And but our current risk assessment protocols, even taught at most of the schools of advanced education, still focus on tooth loss. If you go to any of the learning centers, that's what they focus on. Well, we want to shift that, and we want to look at, we're not looking at bone levels and support for the teeth. We have to look at this issue about excess inflammation and what does that mean to the system. And there's no question we can do that. I can go through this very quickly because you already know you need a couple things to make a fire. You need some bacteria. You need to have some genetics that are favorable to react to that bacteria. And then the environmental susceptibility are all the other things that patients do. Smoke, all the other things that they can change in their environment. And when you add bacteria to this equation that creates an immune response, that's when you get disease expression. And that disease expression is personalized. You can have a Mrs. and a Mr. that live in the same house, eat the same diet, have the same bacteria profile, and you can have one that's sick and one that's not sick. So it's very personalized as to who responds to what. This goes back to the mid-'80s. This was a long time, or maybe it was a very long time ago where Time came out with this secret killer. This was 2004, actually. It goes back to the mid-2000s about inflammation. One of the things that I think you can have in your office and stick on your shelf if you want to talk to your patients, I just have this sitting in all the hygiene rooms, and it's a nice little simple book because this gives me an entry discussion point for my patients. And when somebody's bleeding, I can say, see that book over there? That book over there talks about the inflammation syndrome. And you know what's kind of being redefined in our community right now? Vascular disease. And we know that vascular disease is really a constellation of all these inflammatory things. You know that psoriasis you told me about? And that rheumatic arthritis that you talked about? And that gout that you have every now and then? That's an inflammatory disease. And if we have that coupled with your bleeding gums, it could be a problem. I don't say it is a problem. I say it could be a problem. Maybe we got to go get that checked out. Wow, doc, where do I get that checked out at? Well, I happen to have this guy who can help, who can help us evaluate that. So this is a nice entry point for the discussion. Patients will come in, they'll ask you about it. They'll say, what's this all about? But that's the bottom line. And if you're on the hygiene team, all you need to know is inflammation is a significant issue today, and we want to couple that with maybe some other red flags in the patient's medical history and start to tip them off and share with them how to get help. So the bottom line is this is really what you're trying to do, because this is what you need to do to create the success. You have to get a team of people. Periodontal therapy is a team sport. Disease awareness is a team sport. It's not an individual thing. The whole office has to adopt this. So that's why we're going to create a policy. The bottom line is we're going to create a policy that you represent. You have to represent it. That means you have to live it. You don't just do it when, if you talk to me tonight later on and you ask me what do I do in my practice, we live it. We live this all the time, and you know that from the passion that you've heard from people that get up here. And we want to improve the health of our patients. And if you improve the health of your patients, your practice will be healthier and your team will be healthier. And how does the team get healthier? Because they have more joy. You know what? Remember stress at work? If you just have more joy in your work and you feel like you're making a difference in people's lives and you're part of something bigger than just a procedure, it makes a big difference in your daily life, for sure. And, pardon me? Did somebody? Somebody said something. Hey, by the way, this is a very interactive. It can be a very interactive deal. If somebody wants to say something, in Detroit, we don't even raise hands. We just blurt it out. So just say what you just. That's right. So what about a policy? You have to agree on some things. What do you have to agree on? You have to agree on what is going to be disease in your practice. You heard Dr. Bale stand up here and say, we don't have sound criteria for disease. Well, you know what? You go back and create that. We can help you do that. It's pretty easy. And once it becomes obvious to you, you'll say, wow, why haven't I been doing that? And then once you agree on some things, you need some tools. We've been given a couple tools here. There's some forms to learn about the other red flags of disease. And you need to have these tools because tools will help support the policy, whatever that policy is that you develop. And then there's some steps for how you're going to implement. If you go home tomorrow and just start giving a whole lot of directions to people without some kind of written policy or some kind of idea, it's going to be very complicated. So just give that a little bit of thought. There's implementation steps. And then you have to execute. You have to execute, and then you have to measure the results. And that was the approach I took toward my therapy program, and that's what Dr. Neighbors was talking about. I measure every single periodontal disease I treat. I measure it pre-treatment, and I measure it post-treatment, and I do 2-year follow-up treatment measurements using the oral DNA test to make sure that I know what's going on. And what I think we should do, and I'll say this publicly, I've already said it privately, a couple of us that have a lot of experience with this, we could do our industry a big favor by getting together and putting our protocols together and have everybody standardize at least the protocol they use, and let's look at our next 50, 60 patients and say, if you think the iodine's the best thing, then that's great. Let's all use iodine. If you think bleach is the best thing, then let's get using something so we're not all over the place, because I hear frustration in the room and they say, well, how do you treat that? Or what do you have to do to treat that? You know what you have to do? You have to reduce the bacterial cumulative burden. I don't care how you do it. Do it with the laser, do it with a scaler, do it with chemicals. You can do it a lot of different ways. But I can tell you, the company would tell me that out of all of our studies, we have very, very consistent pre-test and post-test results. We have very consistent, predictable results. So there are some baseline therapies that we probably should think about using on most patients to get us started. And so these are some tools that we did, and we've created a toolkit, actually a toolkit with all these different tools. How to tell a patient how much it costs, how to tell a team what to do. And so this is for another lecture, but it's available, and this is what the impact thing is all about. So here's the bottom line again about the bacteria. Without a specific number of bacteria, a certain type of bacteria, disease just won't occur. That's been said already today. Oral DNA has helped us with that. They've helped us and given us the tools to identify what that bacteria load is. And so and by the way, we've had very little collaboration. We as speakers, have had very little collaboration on our slide decks today. So if you see a little overlap, that's what that's about. I don't need to belabor this, but this is what my office looks like now. We do a lot of testing for salivary diagnostics for caries. We do it for periodontal disease. We do saliva measurements for certain pH parameters. We're looking a lot more like a testing facility than just a repair shop. And that's been really nice. And we get back these reports. I don't need to go into this because we've already done it, and you'll see it in the cases. But this is the key part of the policy. One of the key parts of the policy for me, because I didn't want to create confusion for my patients, so I decided to, and this may or may not be the popular consensus, but I'm happy to be standing here right now. So here's what I do. I decided that I was only going to treat diseased patients. I was going to make it easy. I wasn't going to take my healthy patients and test them. Now, if we come up with a medical reason for why I need to measure the cumulative or the inflammatory burden on my healthy patient base, I'll do that. But I have to make sure that I tell my patients, if you start just testing all your patients, then it's going to be a different challenge than if you just identify your diseased patients and start with your diseased patients. So I said, look guys, we're going to use the periodontal chart, because that's what we have in dentistry. I'm going to use the periodontal chart to help me determine who's diseased. But how am I going to do that? I'm going to look at pocket depths, I'm going to look at clinical attachment loss, and I'm going to chart bleeding. I have to have at least that stuff on the periodontal chart. If you give me a periodontal chart without that stuff, you're not going to work here anymore. I mean, that's what I need to have. I just got to have that. And if I don't have that, then then I'm kind of out of the water. Because I go to offices, they say, yeah, we take periodontal charts. Well, you know what? We just do pocket depth. We don't do clinical attachment loss. In other words, we don't do recession. We just do pocket depth. Well, that's only part of the story. And then we don't do bleeding. Or we do bleeding, but you know, what is bleeding? And Amy mentioned earlier about the endodontic issue, and this communicates with the maxillary sinus. And you know, there's no question there's a host of issues going on here for this patient, very sick. Here's the perio chart, however. Most of his disease is caused by the other bacteria issue, which is caries. Most of this disease is caused by caries, not so much perio. When you look at probing depths here, even though there is some recession and some clinical attachment loss, we always look at the main etiologic factor why the patients lose their teeth. Is it perio or is it caries? And this just happens to be a little bit more on the caries side, but still does have perio. So what do I say to a patient when I see a chart like that? Simple. I said it already once. I would say, Jeff, you have a very aggressive infection, not only on the tops of your teeth, but around the necks of your teeth. And we have a test that we can take that will help us determine the bacteria that are driving the bleeding. In addition to that, there's some implications, potentially some implications to your systemic health. You have some other red flags of disease, and I really feel it's important to get this test. When I make a recommendation, a strong recommendation, I tell them I need this to know how to treat you. By the way, that's another thing that I say to patients a lot, which I think is valuable. I don't tell them I'm taking the test to diagnose their disease. I tell them I'm taking the test so I can better determine how to treat you. In other words, I need that information for treatment. I already know you have disease or I wouldn't be taking the test. So the test doesn't discover the disease for me, it helps me treat the disease. And so that's what I do. So that's what I say to a patient when I see a chart like that. And so here's his initial results, his initial bacteria results. He only had one bacteria over threshold. By the way, the threshold value is there to tell us that the patient has greater relative risk of bone breakdown. Am I concerned about bone breakdown for this patient? Am I concerned just about bone breakdown for this patient? No, I'm not. I'm concerned about some other things for this patient. So he does have TF. He has PM. By the way, this is a bad combination. I see this a lot in chronic adult periodontitis. It's hard to treat, but that's a side story. Then his PST test comes back. PST test comes back, and his PST test is negative too. So his issue is disease, bacterial disease, caries, and periodontal disease. But now I want to get into and help have Amy lead the discussion, because at this point I was smart enough to at least say, Jeff, you need to get a further medical evaluation. Because number one, I want to know, is it appropriate to treat you? Is it now a good time to treat you? Because you know I got to do a bunch of extractions and I got to do scaling and root planing and I got a lot of work to do. But this is what we've been talking about today. This is kind of a little inflammatory panel that we've been talking about today. So Amy, would you mind helping us with this?
No, that would be great. Let me see. Am I on? Am I on? Okay. All right. So first off, excellent case. I mean, really a impressive case. I mean, at 31 years old, just for my benefit, do you see that significant amount of caries routinely?
This guy's 36. No,
yeah,
you know,
36.
In my practice and the demographics of my area, I probably have 4 or 5 of these walk in a year.
Wow.
I don't have that many, but I mean, I had Tom and I had, you know,
yeah.
Those two were both in the same year.
Wow. So one thing I would say, thank you for telling someone at 36 years old that has systemic impact. Because some people think that if you're under 40, the coronary or vascular risk is really not there. When we in medicine, we cannot as easily as you can probe and look for bleeding and so forth. The vessels are hidden under the skin surface. We can't see them as easily. We can't go in and physically assess them. So we've got to rely on biomarkers to tell us the objective story of what's going on with Jeff, right? With Jeff's systemic system. So when you think about an artery, and as I said, there's 6,000 miles of them, right? How do we know what's going on with that artery? So we've got 2 layers that we can objectively look at with laboratory data. And some of the laboratory data has more biovariability than others. So when we look at the endothelium or the tennis court of the artery wall, we have several labs that apply there. We've got HSCRP, and as much press as HSCRP has gotten, it's also the most biovariable lab out there. So just clinically, when I look at his HSCRP of 9.9, and keep in mind, optimal is less than 0.5. So when I look at that and I think, gosh, is that real of the endothelium, or something else skewing it, or is it more of a systemic condition? Once it's over 3, we have to often think something grander or something systemic is driving that, and that's validated in a way by his neutrophil and his white blood cell count are off the chart. So this guy has a true bacterial infection that needs to be addressed. When you look at the endothelium and you look at the microal creatinine urine ratio, which lacks the biovariability, and for a male, it should be really under 5, and you can see his is below the detectable limit. So in a way I go, okay, yeah, Jeff has infection, and clearly the endothelium is handling the pressure at this point, because the microalbumin being below detectable limit of 5 or less for him. Now granted, the lab will say 30 or less is normal. When you look at vascular prevention for men, it's less than 4.5 or 5, and less than 7.5 for women. So at any rate, endothelial-wise, we've got some comfort here. When you look deeper in that artery wall and we look at Jeff's situation, we can look at the lipoprotein-associated phospholipase A2, which, as Brad showed you earlier, that's a real player. That's a player in the disease state, and when that's elevated, stuff is happening within that artery wall. Anything over 180 in a primary prevention individual says that there's endothelial coronary activity going on. His is 192.2. So I would say, oh boy, this is not a pleasant situation. That artery is heated up deep within that artery wall, which is problematic, and he's in a prothrombotic situation. That's an acute phase reactant. So I would look at his situation, I would say 2 things. One, I question, is this real? Blood pressure of 90/60, I really question that in his case. And so I would validate that again and wonder, did they actually get a correct reading, number one? And I don't mean you. You said he brought that reading in, so I question that. Because someone with a high resting pulse rate like this, also, you have to be suspect of a condition like insulin resistance, where they're going to carry a higher resting pulse rate. So just a couple sort of red flags that you should be aware of. And then to see that he has, his endothelium, fortunately, is okay, but he's got some intima activity here. Myeloperoxidase, fortunately, is okay. Fibrinogen's elevated, and he's got an acute infection that needs to be treated. That's how I'd look at that situation at this point.
And then I have the benefit of working with the lipidologist, so there's some additional information for Jeff that maybe you can clarify as well.
Sure. Okay, so when we look at Jeff's lipids, a couple things that I would point out. Look at Jeff's HDL, 32. And when you see a low HDL like this in a young, healthy, fit individual, you need to question why. And 9 times out of 10, we're dealing with a more global issue with maybe some early onset metabolic syndrome, insulin resistant type characteristics. Fortunately, as amazing, we make assumptions about people and we think, oh my gosh, he must be eating terribly or must, be doing this or that. His lipids aren't horrible,
right.
But that HDL being low like that in a young man with vascular inflammation of the intima it's a big deal. And I would question right away, does Jeff have disease or not? Does he have atherosclerosis or fatty streaks in the artery wall that we can document and give us a platform to know, is he really primary prevention? Is he secondary prevention? Because once we know that, then our treatment decisions are going to be very different. Because under a Framingham risk factor profile or even a Reynolds, age is going to be to his benefit. So he's going to appear to be low risk despite what you see here. So at any rate, I would pay attention to this low HDL. And then, of course, vitamin D deficiency is an issue. Lipoprotein A is a genetically inherited lipid abnormality. He's got some uric acid demonstration, which people who are insulin resistant really do not excrete uric acid very effectively. So you're right to say, hey, we got to get a 2-hour glucose on this guy, which is going to be a bit of a challenge because you got to convince him to do that as well. So I like what I'm seeing here. It would make me immediately want to know structure now. I want to know disease, and the carotid IMT, which you did for him, is the next step, right? Because you want to know what his carotids look like. So here's his carotid IMT, and this is a company I'm unfamiliar with, but just to, it's not a report that I'm used to reading, but again, it does give insight. And I just want to point out to one thing down here. Right common carotid artery shows an area of thickness of 1.5. Does that say centimeters?
It does.
Okay, that's weird. Okay,
Yeah,
so that would be a totally occluded vessel, but
Yeah.
really, I'm just unfamiliar with this report, but it's probably 1.5 millimeters of heterogeneous thickness. I don't know. I don't know the report. And the left common carotid artery just shows a 1.5. Heterogeneous simply means it's not quite all calcified yet, according to this report, and it's somewhere in the middle between soft and calcification. Regardless, Jeff has atherosclerosis, so he's now taken from a paradigm of primary prevention, placed in a paradigm of secondary prevention, and he needs to find out why he's got disease, and we have some suspicions of insulin resistance and some different things. He has a lipoprotein A, he has a vitamin D deficiency, he has an infection. So all of that gives us a foothold to treat, and we're not talking about treatment today from the medical side, but if someone's got atherosclerosis, he's at risk for a stroke. I have several professionals under age 40 that have had strokes. Dental professionals under age 40 with strokes. So yes, it could happen to him, right? So he needs things to protect the endothelium, like nitric oxide regulators. He needs things to stop the oxidation in the artery wall, like low-dose statins, et cetera, et cetera, et cetera. So there's treatments that we medically need to join forces with to make sure that he's safe based on this.
So I don't need to show this slide because Amy just summarized his situation beautifully, and Jeff is undergoing some treatment, and we're beginning his dental management. It's a relatively new case. I want to talk about one more patient that came in, Mike. Mike is 5'9". He fluctuates. He told me his weight fluctuates continually between 200 and 250, so he's just a little bit short for his weight. And he hasn't seen a physician. He hasn't seen a physician in about 8 years either. And so you can see this was the after periodontal probing, so he had some significant bleeding around, kind of localized. And Mike had a spotty medical history as well. In other words, he didn't fill, this is out of Patterson, he didn't fill the chart out completely, so that always raises eyebrows why people don't do that. This was his periodontal chart: furcation involvement, gingival margin recession, clinical attachment loss, probing, a lot of bleeding. Clearly, the conversation would say, Mike, you have a very active bleeding, it's not healthy, you have signs of past disease, we have a test that would help us determine what's causing the bleeding. I need that information so that I know best how to treat you. And he consented to doing the test. And then I said, in addition, I learned a little bit about his family, and I said, one of the other interesting pieces of information I'd love to have is the genetic component. In other words, do you have a susceptibility, or do you have a likelihood to maybe mount a more aggressive response to an inflammatory burden? And if you do, I can learn that through the PST test. So Mike said, sure. And so we took the MPP test, which stands for my periopath, and the PST test. He was positive on the genetic side. He did have some AA, he did have some TF, and he had PM. So again, Mike needs to have some treatment. But now, knowing what I have been knowing and how I've been treating patients recently, I want quite a bit more information on Mike before I decide what to do. Now, to keep the discussion objective, there are other ways of finding out the bacteria profile on our patients. This happens to be the Hain test. You'll hear some people talk about this. What my comments about this are, I can tell you I've run several of these, and they're strikingly similar, although not the same. There's some different thresholds, there's some different metrics that are used to determine this, and I would tell you, my comment would be hands down that the oral DNA test is much easier, more user-friendly, better support, and I would just go on the record as saying I prefer that, but there are other alternatives available for you. And again, Amy, if you wanted to help me with Mike now, this is Mike's, and why I broke this out is because today at this meeting, we've kind of focused on these, and Cleveland Heart Lab has agreed to do, that's the inflammatory panel marker that you have in your packet, so you could literally go home and connect with somebody pretty quickly and get this information.
Yeah, so on his situation with the inflammatory,
Doesn't sound like it, Amy, doesn't?
Battery. Okay, there it just
That's
popped
better.
on. Okay. All right, so sorry about that. So in his particular case, well, first off, I love that. He's a little short for his weight, right? That's cute. So one question would be his fluctuation in weight. Just clinically wonder why he struggles so. Does he have a sporadic sort of fight or flight approach towards exercise? Is he doing weekend warrior stuff? Is he safe to exercise like that sporadically? Does he know his body well enough to know what shortness of breath feels like? Or is it just part of his existence? Does he have things like obstructive sleep apnea? Does he have other things going on? So that would be just a big picture to wonder why he fights weight fluctuations so much. That would be one thing. I would love to know his waist measurement because it would help diagnose any underlying metabolic syndrome. So getting a waist measurement would be very valuable for this particular individual. Again, his resting pulse is a little higher than I'd like to see. His HSCRP is probably very real. It's 1.3. Anything over 1, I would pay attention to it. Now in your lab flow sheets, we put 1 as the cut point because that probably contains the most data. I will just tell you, I sleep a lot better knowing if my patient's HSCRP is less than 0.5, because we know that events are mitigated, not mitigated entirely, but we can feel better that that endothelium is very safe. So having a CRP of 1.3, I would pay attention to that. Deeper within the artery wall, I take comfort. I see his LPPLA2 looks pretty good, myeloperoxidase looks good, microalcreatinine urine ratio looks good, and so does fibrinogen. But I would pay attention to the HSCRP, and I'd wonder a little bit about metabolic syndrome and insulin resistance with this guy as well.
And then again, because I've built that bridge with the lipidologist, we have a little bit more information on Mike.
So one thing less known, I think, Dr. DeFranzo, and Brad had mentioned him earlier in his talk, really the father of insulin resistance. In a Caucasian male, you can diagnose insulin resistance if the triglyceride to HDL ratio is over 3.5 rather. In an African American, if it's over 2.0, you can diagnose insulin resistance. So clearly he's got insulin resistance, there's no question. He also has a hyperlipidemia problem. He has a high cholesterol problem, which could lead him into trouble. Fasting blood sugar is 90, A1C is 5.4. That would not dissuade me from demanding a 2-hour glucose tolerance test. I would demand it because I want to know where he's at with the challenge, a glucose tolerance test. Vitamin D deficiency, Detroit is probably as common as Spokane, Washington, right? ApoE44, so that's interesting. So that gives some genetic backdrop and objectivity to how this guy should eat. How his body's going to process fats, carbohydrates, even alcohol. This helps us determine that, so we can give objective dietary information that'll really hopefully stop this fluctuation of weight management. Uric acid is a bit borderline, and he also has a high homocysteine, which is a biomarker as well. So.
And then we're working with, we obviously have talked with Kim today, we're working on getting, again, a more familiar and a friendlier CIMT evaluation, but this happens to be his. And
so right here, okay, so one, kudos for starting the process of getting IMT, right? Number one. This report challenges us clinically for a couple things. One, to have some objectivity to what we're really looking at. But two, these two reports that were generated for IMT, they're going to be impossible to follow that patient over time because you want to make sure you lack the variability, and that test is going to be the same from point A to point B, and you want to know if the treatment's improving the situation. You have to have appropriate IMT measurements. Regardless of all of that, although we don't have measurements, they state this statement: both carotids have significant atheromatous plaque. There is minimal intima thickening seen, but they don't give us measurements and they don't give a lot of information. So I would encourage you to use a service company that has the reproducibility data so that what you're getting is real. They can come into your office or to your medical partner's office and get those tests routinely. You can do it yourself, it's more tricky, and you need to make sure you're doing it the right way. So this adds a little bit of confusion, but based on just those words alone, I would say he's probably secondary prevention as well. Yeah,
that's what I thought too. And then if you could comment on the dental treatment, because my question is, when a patient comes in and they show a lot of oral disease, and I know they have a systemic component, there was a study some time ago about could the initiation of invasive dental treatment cause a problem for the patient vascularly, so I have to make some judgment call as to when to treat the patient.
So this particular question number 2, recommend lipid management for 2 to 3 months and additional inflammatory testing prior to
scaling and root planing.
Scaling and root planing. I would challenge that a little bit and say go for it with this guy. His vascular inflammation looks stable. The sooner we can put out that infectious process and move this guy while you've got his attention, is probably a good move. And then while you have a captive audience, get him doing the other pieces. But the inflammation is really where you take your comfort. Having hyperlipidemia does not preclude your opportunity to treat that patient dentally. The ones that, well, okay, so if you've got an endothelium that's hot and an intima that's hot, so if his microalcreatinine urine ratio was up and his LPPLA2 was up and a myeloperoxidase was up, I would give pause and caution to say, let's put this fire out and make sure this patient is safe, and then do the treatment. Really, I mean, if they're up, then you have to at least entertain the concept that they are at risk at that moment. The other thing, too, is the medicines work quickly, by the way. I mean, there's data to show that certain medicines for the vascular system put out the fire within 3 days. So it goes to prove also that the half-life of these medications is not very long. So if your patient who has excessive periodontal disease forgets their medication when they go on the cruise, doesn't floss, and has an active periodontal condition, they could have a heart attack or stroke, right? The medicine is only as, I mean, it continues to have lasting effect, but the other point is the treatment works fairly quickly. And sometimes when patients go into surgery or they have to have surgery, we may have to up the medical management to get the fires out, and then we can always back things back down again when appropriate. But that's where you need a medical counterpart to help you balance that act. And to Dr. Nagelberg's point earlier, I thought, where's Dr. Nagelberg? There you are. What you said earlier really touched me, and I think I really want to bring this to light one more time. When you said that when that cardiologist told you that we need to withhold surgery until you give approval, and you used the word humbled, and you felt a real sense of responsibility there, as well you should. The dental community and the hygienist community have a huge role in heart attack and stroke prevention. So I just appreciate that you're saying that, and the fact is you saved that woman's life probably, because had she gone in for surgery with, you just signed that off, who knows if she would have come out of it, quite honestly. So huge compliment to you on that, and it is a huge responsibility.
Why I think this is significant, this was Inside Dentistry, and this was back in May of 2012, but it talked about 72% of the population sees their dentist regularly, and only 53% see their physician regularly. I've just shown you 2 cases where patients have significant disease, they have huge concerns, neither of them had seen a physician in the last 5 years or more, and the dental office had an opportunity to be a significant game changer for their health. And so I just want to make sure that everyone's aware that you do have a huge, huge opportunity. And by the way, Mike, the reason why he hadn't been to a physician in 8 years, because he didn't want his rating on his life insurance to change. He was in a certain premium bracket. He wanted to stay in that premium bracket, so he knew he was heavy, and people avoid they do all kinds of crazy things, and you have no idea why somebody's avoiding the right kind of care. So it is about the collaborative relationship. We have to build that. And that collaborative relationship for me has literally taken 2 years to really build and to continue to build. And I still feel apprehensive in my community when somebody says, "Hey, what physician do you send your patients to?" I'm a little bit tight with that information, because I really think it takes some time to get people to understand each other. And the gentleman that I'm working with just a couple months ago went to a Bale Donine course. And so to have a physician and a dentist team already here hearing the same information is critical and key into being successful in the relationship. There's a couple things I wanted to let the dentists know that they need to be aware of. Number one, I can tell you that you need to know the red flags of disease, and we've given you lots of tools to do that with. You need to know for sure you're an important part of the wellness team. I wanted to expose the Bale Donine concept to the COI Center, but I'm a very critical practitioner, and I like to do things a certain way. And so I asked Brad, and I don't know if he even remembers. I asked Brad a year and a half ago. I said, I don't want to overstate the significance of what it is that we do. Because you know how that goes. You go and you talk to somebody, and the doctors say, "Oh, it's not a big deal," or whatever. And something was said to me that was important. And Brad said it actually, and he said, you never know. He said, first off, you have to understand your position in the team. And he said, you have no idea who is going to be the person that mentions a piece of health-related information to your patient that makes them well. You don't know if it's going to be the chiropractor, the physical therapist, the dentist, the physician. So you do have a part. You have a very, very important part. And he said, you dentists have to get off the inferiority complex to physicians, and you have to get that, you have to get off that horse, feeling like you don't have a place, because we do have a place. I know sometimes I call it a stent and it's a stint, and I know or whatever way. I mean, I don't get the words right all the time, but that's what it's all about. We have to learn. So it's going to take time to learn the language, and it'll even take longer to learn the significance of the language, because something else was said to me recently. Dude, you know enough just to be dangerous. Right? I mean, when we're trying to learn a different field, we don't know that. We have to learn that. We have to be humble, and we have to reach out and get help. And that's what we have. And so that's significant. I encourage you to do that. So don't feel bad because you don't know, because I don't know either, and we have to get help. And I can tell you that physicians, this has been hard for me. Physicians are a little bit reluctant to order tests that they don't understand and they don't know the significance of, because the test order typically has to treat the test results. And if they're not comfortable, we need to get them help so they can get the information they need to feel comfortable. And I can tell you there's some momentum gaining. There's some momentum gaining, and the resources are out there. And specifically, they can come and take a Bale-Donine course. Physicians, I think if you're a physician in the room, you need to be aware that dentists are going to be a little shy. Maybe I'm not so shy, but a lot of dentists are going to be a little bit shy and a little standoffish. And they're going to be, most dentists will be new or unfamiliar to using a saliva profile. If you think that all the dentists are at this place in their practice, I go around the country speaking about this, and I can tell you, most dentists, when we're in a crowd and we say how many people are using salivary diagnostics, less than 10% raise their hands. So if you go back to your community and you call up the dentist, Joe Dentist next door, and say, hey, I really want you to use that saliva test, and they say, what are you talking about? Expect that, because they might not know. What they need to do is they need to do the same thing in continuing education that you've done, and that's take that next advanced course. Periodontal disease cannot be visually diagnosed. It's just over, game over. If you're looking in thinking somebody looks great and you're not taking a perio probe or a measuring tool that we have today, you're missing it. And physicians need to know that you can't see it visually, but there are some things that you can see visually that can tip you off. And so a few basic questions on your health history could be very revealing, and it would be these questions. One, ask them if they go to the dentist. If I would have, just like I asked my patient, did you go see your physician? Just do the same thing. Do you see your dentist regularly? Do you have red, swollen, puffy, or bleeding gums? They'll say, no, they don't bleed except when I floss. Well, how often do you floss? About once a month, right? I mean, that's typically what you'll get, so they might not know their gums bleed. Do you have any missing teeth? If they have missing teeth, you ask them, how come you lost your tooth? A lot of them will say, well, it rotted out, or it broke off, or some will say, well, I don't know, it just got wiggly and came out. That's what Tom said. Are the teeth getting longer? Are they experiencing recession, which is when the gum shrinks down below the root and you see root? Teeth, when they get on loose ground and weak soil or weak foundation, they shift and they flare and they move. So when you see people, like the Billy Bob teeth, those teeth move because they lose support. And then bad breath, black spots or holes. These are all signs, things that you can do in just a short amount of time. You can ask a couple questions, look in the mouth, and you can see some red flags. Physicians, what do the physicians need from us? We have to be respectful of the physician's time. I can tell you, dentists, the physicians are very, very stressed right now. I don't know what's going to happen with the administration change, but I can tell you that physicians are very stressed. And there's a reverse phenomenon happening in the world of medical and dental health right now, and the physicians are having more and more trouble with reimbursement. Their salaries are going down. Hospitals are buying practices. It's a big problem, and we have to be respectful of physicians' time. So if you go running back with a big, thick manual and you say, hey, doc, I really want to talk to you about all this stuff, be ready. I have, and I already know what to say. I have tried to get into certain practices in town to do lunch and learns, and they'll tell me, maybe we'll give you 10 minutes. Maybe. Okay, you're not going to get an hour to go and sit and talk to somebody about gum health. You're going to get a couple minutes. So Amy, something brief and succinct for this group would be really helpful. Clarify why your patient's being referred, because here's what's going to happen. If you find a lipidologist or a vascular specialist or somebody in your community, but it's not your physician next door, do not assume that your patient's going to change that physician relationship. I'm never about breaking great relationships. So what I would say to my patient is this: I have somebody who could really help give us this vascular piece. Let's have them do an analysis for you, and they'll augment your care. That it can either augment your care with your current physician, or they could maybe someday become your physician. But I don't assume. So I make sure I clarify with the physician why that patient's coming over. I don't want them to be assuming that they're going to be a total new patient for a long term. Give them a summary of the current disease status. We have letters for that. And again, assess the patient's motivation. Why are they going? Do you want them to go to have an analysis to help you, or do you want them to find a new doctor? What do dentists want from physicians? We want the physicians to acknowledge that our contribution is meaningful. I think that's been set home. We definitely want to be open to the concept of early disease detection, and we want them to help us advance our education. And again, consider ordering a test that might affect our treatment. We're part of the treatment team, and so if LPPLA2 will help our treatment, consider ordering that test and let us interpret what that means and what we could do with it. So that would be helpful. Now, this is what periodontal disease used to look like when I'd go to a lot of the seminars, right? Periodontal disease, everybody knows this patient has disease. Well, guess what? On Monday morning, a lot of your patients are going to look like this. And these patients, some of these patients are going to have significant disease. It's not going to be so obvious. So I challenge you to look at the red flags, take the periodontal charting information, use the testing, get help from someone who can help you to implement this in your practice if you don't feel like you can do it on your own, and enjoy the journey. It's an absolutely fantastic experience. Thank you.